Hi, my name is Lacey Lyman.
I am Jamie Fields.
I'm Jamie Anderson.
And I'm Robert Bacon. We're all fourth semester students at the College of Southern Nevada. Our topic today is on the prevention of medication errors due to illegible handwriting.
CPOE.
The student nurse that has ever read a single chart can relate to this dilemma.
Random audits of medical records.
Our topic today is on the prevention of medication errors due to illegible handwriting here in the hospitals in Nevada, within the United States for that matter. Not only do medication errors cause significant physical and emotional damage due to an immeasurable extent, they also degrade the reputation of healthcare as a profession. The Institute of Medicine released a report, To Err is Human, Building a Safer Health System. According to the report, between 44,000 and 98,000 deaths may result each year from medical errors in hospitals alone. And more than 7,000 deaths each year are related to medications. Additionally, it is estimated that between 6 and 10% of those 7,000 deaths are caused by illegibly written orders. It can't be determined with complete certainty the actual accurate amount of injuries and/or deaths because many incidences are left up to the integrity of the healthcare professional committing the mistake to actually report. With the severity of consequences from making these mistakes, even the most honest of professionals wouldn't risk ruining their lives and the lives of their families by owning up to their mistake. Here's some prime examples of poorly written orders we found by searching the internet. Can you read this prescription? It is for Actonel, number 30, 5 milligrams, 1 tablet PO, QD. How about these drug orders? Line 1 says, give azithromycin 250 milligrams IV. Line 2, daily. Line 3, DC Pulmicort, Marinol, Lasix. Line 4, diflucan, folic acid, Neurontin. Line 5, Megace, vitamins, K-Phos, Disulcid. Line 7, Decadron 2 milligrams IV daily. How about this order? Although it looks a lot like Coumadin, the order is actually written for Avandia 4 milligrams PO QD.
Any nurse or student nurse that has ever read a single chart can relate to this dilemma. So rather than dwell on the obvious, we would now like to focus on possible solutions. We know that change usually comes slow in large organizations, and that the mentality of this is how we have always done it is sometimes hard to change. However, we believe that as a part of evidence-based practice and to grow in a positive direction as a profession, we have an ethical and moral right for the greater good of the population to make necessary changes. There are several programs recommended by the Joint Commission that have been instituted in hospitals throughout the country. These have been proven to be effective in solving the problem of illegible handwriting. For example, the use of pre-printed order sheets, which have a list of common medications, as well as common doses that physicians can simply circle or check off. Or the use of email to transmit physician orders in which an electronic version of a pre-printed medication order sheet is sent via an electronic secure web connection. Another great idea is launching a legibility campaign where signs are left in areas where doctors write their orders and their prescriptions, and signs are put to remind them to use a ballpoint pen, write clearly, and sign and date their orders.
Another great idea is to track handwritten orders for performance improvement. Random audits of medical records, which identify individuals who have trouble with handwriting, can be performed following the aforementioned criterion. 3 reviewers grade handwriting on a pass-fail basis. If failed, options are to 1. Take a remedial handwriting course, or 2. Print all orders or dictate orders at the expense of the offending prescriber. In January 2005, the Medical Executive Committee at Baptist Hospital of Miami created the following policy it shared with JCAHO representatives. First, charts will be screened for illegible notes or orders. Next, potentially illegible charts will be brought to the Medical Records Committee where physician and others are permitted to comment. If there is agreement among committee members that the document is inadequate because of legibility, the physician at issue will receive a letter requesting improvement. Further, the physician is advised that his or her notes will be monitored for the next 30 days for improvement. Then, if there is no improvement, an intervention is required, such as a handwriting course or requesting the doctor to find someone to write or type his or her note. Finally, as a last resort, the doctor could potentially be suspended until he or she comes up with an action plan for improving legibility. The cost to form a committee such as the one just described is minimal, yet still a very effective way to prevent simple errors that could cost potential millions.
Finally, our decidedly most accurate and user-friendly solution, CPOE, Computerized Physician Order Entry. This is a process where physicians write orders for hospitalized patients using a clinical software application. This application will not only record the order as permanent documentation in the patient's chart, it will also compare currently prescribed medications, drug allergies, standard doses, and potential drug interactions of the most recently prescribed drugs, in addition to completely eliminating the potential for illegibility. In an article called Death by Handwriting, it states that a 1998 study by members of Harvard University's Medical School, School of Public Health, and others, published in the Journal of the American Medical Association, found the use of CPOE reduced the rate of serious medication errors by half. Furthermore, more recent studies report that CPOE has reduced errors by as much as 81%. This could save the hospital $5 to $10 million annually by preventing adverse effects from illegible and poorly written drug orders. CPOE is only in use in a small percentage of hospitals. Reasons for low adoption rates include hardware and software incompatibility, disagreement on clinical terminology, expensive training that is required, older physician resistance, and most importantly, expense. CPOE costs $8 million initially, and then it is $1.3 million annually to operate. A press release from July 20th, 2006 by the Institute of Medicine states, there is insufficient data to determine accurately all the costs associated with medication errors. The conservative estimate of 400,000 preventable drug-related injuries in hospitals will result in at least $3.5 billion extra in medical costs this year. A study of outpatient clinics found that medication-related injuries there resulted in roughly $887 million in extra medical costs. And the study only looked at injuries experienced by Medicare recipients, a subset of clinic visitors. None of these figures take into account lost wages and productivity or other costs. In conclusion, we feel every hospital in Nevada can implement a system to work towards improving legibility of orders and prescriptions regardless of the type. Many of the solutions we presented are low cost and can be an initial step towards reducing the amount of wasted time trying to contact the physician to verify the order, and in cases where assumptions are made, can prevent patient deaths and errors that occur.